All right, class. I'm going to begin the lecture for this week, week 4, and I just want you to look over the information in chapter 14 in your DA book, and that chapter is titled Enteral Tube Feedings, and I'm just going to talk a little bit about tube feedings because with your Nursing 122 course, your skill for the lab for that course will be inserting NG tubes, and this is very important to kind of understand what these tubes are about, because many times after inserting an NG tube, a tube feeding or nutrition may be ordered for the patient. Okay, so I created this PowerPoint just to provide you the important points from this chapter and to kind of understand the different ways in which we deliver nutrients to our patients. Okay. And what enteral nutrition is, it refers to the delivery of nutrients that are directly into the digestive tract, anywhere from a tube being directly into the stomach, into the duodenum, or in the jejunum. Okay, they're provided for patients who are unable to eat, or for patients who are eating inadequate amounts but still have a functioning GI tract, meaning that they're able to absorb those nutrients and hopefully provide nutrients that help the patient get better, whatever illness he may have. And nutrition received enterally is generally preferred over nutrition received intravenously, because with this route we can provide a lot more calories and be very specific about what nutrients we want to give to the patient. Whereas when you give IV fluids, it's just more for hydration and doesn't really provide the patients with all the necessary nutrients, vitamins, minerals, such as your macronutrients and your micronutrients. So with nutrition, we can be very specific on what type of feedings we want to give the patient depending on his specific illness or disease. Nutrients that pass through the intestine stimulate normal GI functioning, and they also maintain the intestine's immunity. And nutrients present in the GI tract stimulate the release of digestive enzymes and hormones that keep it healthy, and they also process that bacteria as well. So that's why it's really a better route to go than to just keep giving someone IV fluids, especially when we know that it's going to be a period of time before they really can eat adequately like you and I normally do. Now let's talk about the different routes of administration. Enteral nutrition can be delivered by several routes. We could put feeding tubes through the nares into the stomach, and that's what you may do for your skill in Nursing 122, and we call those NG tubes. We can also place it through the duodenum, which is a nasoenteric tube, or through the mouth into the stomach, which are orogastric tubes. So it just depends on where that tube is placed at. Now remember, when we put these feeding tubes in that are placed in either the mouth or the nose, they're temporary. We only have them in our patient for about several days to weeks. We don't want to keep those in for a long period of time. So if we know the patients are going to be very slow in progressing to oral foods, then we might want to think about what's our next way in which we can deliver nutrients and calories to our patient to help them get better. So we might go to the route of placing enteral tubes directly into the stomach or small intestine through a surgical procedure, and we call those percutaneous endoscopic tubes, or G tubes. And the choice depends on why the patient needs the feeding tube and how long it's going to be in. So we also can deliver this formula in 4 different ways. We can provide the solution to the patient by way of bolus. We can give it to him continuous, or we can give it through cycle, or through intermittent. All right, and I'll go over those in a little bit more detail of what those consist of. Now, delivery type depends on the route of administration, how big and the size of the feeding tube, what equipment you have available, and how well the patient can tolerate it. So when we talk about a bolus tube feeding, that's an amount of nutrients or a formula that's administered over regular intervals in large quantities over a relatively short period. It tries to mimic that natural meal and used for feedings in the stomach. Usually we give about 200 to 400 milliliters over about 15 to 60 minutes using gravity flow. Now there are some disadvantages of using the bolus. We see more GI distress from that, where the patient can become nauseated. They may even vomit. They also can have diarrhea, cramping, and bloating. And there's also a higher risk of aspiration. Anytime that the patient may, vomit, there's always that chance of causing the person to possibly aspirate. The next one is a continuous tube feeding, and this delivers a constant amount of formula using gravity flow or a feeding pump, and this is appropriate for a duodenal or a jejunal feeding. We use this method or this delivery system for patients that are very ill, and it will cause less GI upset. There are disadvantages to the continuous feeding. It's increased bacterial growth in the stomach due to the higher pH levels from the constant presence of formula. The next one is cyclic tube feedings. That's pretty much the same as continuous delivery, except it's infused over a period of 8 to 12 hours, often during the night when the patient is sleeping, and it's used for malnourished patients, or it might be used for malnourished patients who you might be supplementing their own oral diet. Maybe they're just still not taking in enough calories or food, okay? And the last one is your intermittent tube feeding. It's very similar to the bolus tube feeding. It's administered in equal amounts throughout the day using smaller volumes and longer administration times. And this might be a total of 250 to 300 milliliters using gravity flows or pumps. The advantage of the intermittent tube feedings, it allows for a 4 to 8 hour period of bowel rest, which allows the stomach to return to a more acidic state. And again, patients are not attached to tubes, so they have a little bit more freedom and are able to move around a little bit better. Now these are the major indications of why we would see enteral feedings or nutrition ordered for our patients. Obviously, if you've got a patient that's at high risk for aspiration, a patient who has difficulty chewing food or swallowing food or fluids, a patient who might have an intestinal obstruction, a patient who is in a coma or has some kind of altered level of consciousness, a patient who has some kind of GI tract disorder, injury, or surgery, someone who suffers from severe burns, a patient who may be on a mechanical ventilation, or anyone that may suffer from malnutrition. Now let's talk about the types of formulas that we see out there, because obviously that will be specifically ordered by the healthcare provider, and the choice of formula depends on the patient's specific nutritional needs, the presence of GI problems, specific disease processes such as the liver, kidney, or renal disease, and it's also divided into 3 categories by composition, either a polymeric, monomeric, or disease specific. We also I know, I was typing. I'm trying to record. Not record, I'm recording, so I just waited. I heard the door open, so I put it on stop, so I didn't know if the dogs would bark. Okay, thanks. Oh, this is what he does. I have to stop it every time he coughs. Well, every time he sees the door closed, so you don't have to close it if you just kind of give me privacy. I appreciate it. Just leave it open in case he wants to get a drink or something. These are some of the nursing care that we should follow when providing our patients with enteral feedings. Obviously, first of all, verify the order, including the type of formula, the route, the delivery method, and the rate of administration. We should label the bottles correctly, maintain a septic technique. If they have an NG put in, we want to make sure that it's verified, so we aren't going to cause the patients any additional problems. When giving a enteral feeding, elevate the head of the bed 35 to 45 degrees. If it's a bolus, we would definitely, or intermittent, we would aspirate for gastric residual. And then, of course, be prepared to manage complications. And your book talks about a lot of these, all of these in more detail. So make sure that you review those. I put, obviously, the general gist of what you should be doing as a nurse to keep your patients safe and to prevent complications from occurring. So this pretty much is are the main key points from enteral feedings. There is the next section about giving medications through a feeding tube, and you'll learn about this in your Nursing 122 lab, because many times we do administer meds down these feeding tubes, and but for right now, just in the Nursing 124, in the pharmacology course, we're just going to talk about enteral feedings as well. All right, so let me know if you have any questions on this, but at least this is a good way for you to study the major key points from this chapter. And I will definitely download this or upload this in your Canvas course under week 4. All right, class, now I want to just kind of go over the highlights of Chapter 12, also from your DA book, Intravenous Delivery Systems and Equipment. All right. As with any chapter, there's always the objectives, because you will be learning this skill in Nursing 124 lab about starting an IV and learning the difference between peripherally placed and centrally placed IV catheters, looking at the different types of solutions such as crystalloid and colloid IV fluids, and then knowing and understanding and doing the necessary checks and safety precautions that must be taken before we actually infuse IV fluids. And then looking at the purposes of primary and secondary IV administration sets, describe the differences between manual gravity flow infusions and infusions using electronic drip controllers, infusion pumps, and syringe pumps, and knowing all the parts of an IV label, and explain the function and safety features of a patient-controlled analgesic pump. So let's just talk a little bit about introduction to IV therapy. IV therapy is the infusion of fluids into a vein for the purpose of providing fluids, blood or blood products, medications, and nutrients, such as vitamins, minerals, electrolytes, carbohydrates, proteins, and fatty acids. Fluids are infused to correct dehydration, improve electrolyte balance, provide nourishment for individuals who cannot eat, or to give medications. And medications that are infused directly into the blood vessels allow for more rapid absorption and distribution compared to other routes. And we might see maintenance fluids, which are fluids that are prescribed to maintain the body's basal metabolic needs, that help to kind of replenish fluid loss due to metabolism and water loss through normal body functions. And then we have replacement fluids that are given to replace fluids lost through bleeding, burns, diarrhea, vomiting, a patient who has excessive fever. They're losing a lot of fluids in that way. So that's the reason we may provide replacement fluids as well. IV catheters. Those are usually hollow plastic tubes of varying lengths and diameters that surround a metal stylet. And the stylet has a sharp point on one end to pierce the skin and vein. It also functions to keep the soft catheter tube straight during insertion. And once the stylet and the catheter are in the vein, the stylet is removed and the catheter is left in place. And so it's more of a, just like, almost like a plastic tube. Kind of resembles a straw, but it's obviously much tinier, so it's obviously able to fit into a vein. And we have various lengths and sizes depending on the lumen of the needle. Anywhere from a 14 gauge all the way to a 21 or a 25 gauge needle. So it just depends on what we're using the IV solution for. If it's going to be short term, and obviously the quality and size of the patient's veins as well. So the first type of IV is a peripheral IV catheter, and the catheter that is placed into a vein on the hands or arm, and it can be placed by nurses or other trained healthcare providers. And as you can see, this is a perfect example of one. Now, many of your facilities, whether it's a hospital or a place where we provide health care, will have various types of peripheral IV catheters, just depending on what company produces them. Your Cleveland Clinic may have a different type of IV catheter that we use compared to possibly University Hospital. It just depends on what the hospital decides to order, and then that's used uniformly throughout the whole hospital. It's just more for cost containment as well. And then we have central venous catheters, and those are catheters that are placed into a large vessel of the body, say in the jugular vein or in the subclavian vein in the chest. Those are placed in by surgeons, usually after a major surgery, or if we're giving TPN or some other solution that requires more of a larger vein to infuse that type of solution. And then there's also a peripherally inserted central catheter, and we might know that more as a PICC line. And that's a central line that is placed in the arm and threaded up to the heart. And some NPs can do that, but not usually a registered nurse. That is not in her scope of practice. All right. Here's a picture of PICC lines and central venous catheters, and you can see how it is placed in the subclavian into the right atrium. And this is a PICC line, as you can see, is threaded all the way up into the right side of the heart as well. So those are where that actual tube is going. And before we use these, obviously, we check for placement before we actually can use them for IV fluids or whatever. And remember, just like our enteral nutrition, IV fluids can be infused continuously or intermittently, and continuous fluids are prescribed for patients who need fluid, electrolyte, or nutrient supplementation over a long period of time, days to weeks, and intermittent infusions are ordered for patients who require IV medications to be administered periodically, such as an antibiotic or something like that. And these are types of IV fluids. They can be divided into two main groups, crystalloids or colloids. Crystalloids contain dissolved substances such as sodium or chloride, and they may also contain dextrose, which provides the body with carbohydrates. Those are used to treat dehydration and to correct a lot of the electrolyte imbalances our patients may have. And then your crystalloids are something like normal saline, half-strength saline, D5 in water, D5 in half-strength, your D10W, your Ringer's lactate, your plasma light R, and also a combination of saline and dextrose solutions, such as D5 in normal saline and D5 in half-strength, such as you see at the bottom of this slide. So those are some of the examples of your crystalloids. So I'm showing that on the screen. You do have this PowerPoint in your Canvas course as well. Now your colloids are more larger undissolved particles such as proteins, carbohydrates, fats, or animal collagen such as gelatin. And these particles increase the onconic pressure within the blood vessels and pull excess fluid from cells and tissues into the bloodstream. They're also called what we know better as plasma volume expanders. And those are for patients who might need more vascular volume, patients who are bleeding when blood products are not immediately available, or even patients that might have protein deficiencies that cause severe edema, where they have a lot of that third space shifting. And here's an example of that. So here's your colloids, and then here is those types of IV fluids. Colloids increase onconic pressure by pulling fluids from cells and the spaces in between the cells. So they actually bring that back into the vascular volume, because they bring them into the spaces in between the cells. Okay, so I think that picture helps a lot. And these are some of your commonly prescribed colloids: 5% albumin, 25% albumin, which is a type of protein, dextran 70, dextran 40, and I had a starch as well. As again, they're called plasma protein expanders. Okay, these are just some safety precautions. Obviously, before infusing any IV solution, these are some of the safety precautions. Check the provider's order to ensure that the correct type of fluid has been selected, and you should really be aware of what kind of fluid that is, whether or not it's a hypertonic, hypotonic, or isotonic solution. Remember, IV fluids are considered to be medications, and you need to follow the 6 rights and the 3 checks before beginning an infusion. Inspect the outer wrapping for tears or puncture marks, and if the wrapping has been compromised, follow the facility's policy for disposal. You would never use that on a patient. Check the manufacturer's expiration date on the bag. Do not use an expired bag of solution. Remove it from the storage container and send it to the appropriate department for disposal. Remove the bag from the outer wrapper. Look at the bag for puncture marks or leaks. And the bag may feel slightly damp from condensation collected during the sterilization process, but it should not be leaking fluid. And you'll notice that when you take them out of that plastic wrap or that bag. So you want to look at the solution to see if it is discolored or contains any solid matter, and apply the appropriate labels to the bag as required by the facility's policy. And some facilities really do require you to double check the fluid and how fast it's supposed to run with another RN, and then you usually initial that label. When I was doing clinicals out at Lakewood before they closed, that was the policy on the floor that I worked on, and that was really good because it really made you go back and look at the original order to make sure that you were looking at the last order to determine if you were hanging the correct solution and how fast it should go. Because a lot of times with our patients, these orders change from day to day. The solution may change, and also the rate may change. Maybe the patient, when they first came in, they were not doing very well and were not able to take a lot of fluids by mouth, so their fluid, the rate may have been 100, 125 milliliters an hour, but as the patient began to get better, maybe now the rate is down to 50 mLs an hour. So I think that double checking with an RN is a good thing, so it prevents a lot of med errors that can be made with IV solutions. Some fluids may require special tubing or filters, or may require special handling during use, and read any accompanying directions in the package. Insert before beginning the infusion if the equipment is unfamiliar to you. This is some of the equipment you may need for IV therapy. After the catheter has been placed in the IV solution, includes an IV administration set or IV tubing, a controller, infusion pump, or syringe pump, unless the IV is to be manually controlled, or necessary labels. All IVs in hospitals and facilities are put on a pump, unless right now that we'd have an over amount of admitted patients because of maybe a pandemic, and that we don't have enough pumps to go around. But for the most part, all your IVs are going to be put on infusion pumps as well. And an IV administration set refers to the tubing through which the IV is infused, and administration sets are categorized as primary or secondary depending on the purpose of the IV infusion. Secondary is what we kind of hook into that primary tubing. Say, for instance, if there's an intermittent solution, such as a medication that may have to be given, every 6 hours, 12 hours, or whatever. It's not going to be hanging continuously, but we can cook it into the primary IV tubing as long as all the contents are compatible with each other. So what we mean by a primary IV administration set is that infuses the main IV solution, and primary tubing is anywhere from 39 inches to 100 inches to allow your patient to move around more freely. And the appearance of a primary IV tubing varies from manufacturers to manufacturer, but all have the common features of an insertion spike, a drip chamber. That's that plastic tube that you see the drip, coming down. And that drip chamber is the diameter of this tube determines the drop factor of the tubing, important when infusing IV fluids under manual control. And that's how we calculate drops per minute. And in order to solve those calculations, we must know what the drop factor of that tubing is. And some of the drop factor comes as 10 drops per milliliter, 15 drops per milliliter, and then your microdrops are 60 drops per milliliter. And each milliliter of fluid that collects in that drip chamber contains a known quantity of drops. And some of the common ones, just like I said, are 10 drops per milliliter, 15 drops, 20 drops, and 60 drops. Tubing with drop factors of 10, 15, and 20 drops, those are known as macro drops because they drop bigger drops, and tubings with drop factors of 60 drops is known as a micro tubing. And then with your IV tubing, it contains at least one roller clamp or side clamp and 1 or 2 injection ports. I'm just giving you this information because you will get this equipment in your lab when we hopefully have you come back in the summer to go over your labs, because your skill for nursing 124 is to do the injections and then to start an IV as well. This is your primary administration set, and you can see that this is your spike, and this is your drip chamber, and this is obviously your roller clamp. Okay? And then this is what your secondary IV administration sets are. They're shorter than primary sets, and they're used to infuse medications that are needed intermittently, such as antibiotics, or continuously, such as insulin, but at a much slower infusion rate. Secondary infusion sets also have spiked ends and a roller clamp, but do not have extra infusion ports. Secondary IV sets may also be called piggyback sets because they piggyback onto the primary IV tubing. And this is what this looks like, just so you see this. And you can see this, this will spike into the little partial fill bag or the little small bag of maybe medication or an antibiotic. And then this kind of piggybacks into that top port in your primary administration set. And before any IV tubing is connected to the patient, prime it to purge of any air. Follow the directions on the tubing, wrapper, and your facility's policy for priming IV tubing, obviously. So here are your IV fluids may be administered via drip controller, infusion pump, syringe pump, and fluids may also be administered manually. That is without a pump, and that's when you would count drops per minute. And this goes on to talk about your drip controllers, your infusion pumps. I'll let you go over these on your own. And then, like I said, we're going to work with those when we get you into the lab so that you're familiar with this equipment. And here's an important caution when you're talking about infusion pumps. They are not without danger. Pumps may continue to infuse fluids into the patient's extremity, which we call as an infiltration, as long as the pressure of the surrounding tissues does not exceed the pressure of the pump. And remember, any time a fluid that infuses outside of the vein and into the tissues can actually cause tissue damage. And if the pump is programmed incorrectly, fluid can be infused at the wrong rate, and the patient may receive too much or too little fluid or medication. So important to know. And then this is just about syringe pumps, and then just talking about labeling IV infusion bags as well. And this might be a typical sample infusion bag label that you may want to see. It's just got the patient's name, the date, the time, by who, the solution, and the flow rate, and when that bag would expire, especially if it's not infusing at a very high rate. Usually we only keep IV bags up for about 24 hours, and then it's changed. And before you put a new bag, it's always important to know if the patient is still going to have their IV infusing, and you might want to check with the doctor before you put up a new bag, because maybe you just hang a new bag and then the docs come in and he says, oh, I'm going to stop their IV fluids, and then you hate to waste that kind of fluid. So as I said before, IV tubing expires within 24 to 96 hours after removal from its sterile packaging, depending on the fluid being infused. So just refer to your facility's policy, okay? What? All right, so IV tubing set should be labeled with the following: date and time the tubing was opened, expiration date and time, initials of the nurse. And IV tubing does not need to have patient identification on it because it's not specific to that patient. And these are little tags you might see put on the IV tubing when it was started, the discard date and your initials as the nurse. Now this is what we're going to learn how to calculate infusing IV fluids using manual gravity flow. Fluids that are administered manually without the use of an electronic infusion device utilize the force of gravity to instill fluids, and the rate at which fluid flows through that IV line depends on the height of the bag. And the higher the bag, the faster the flow rate, and the size of the IV tubing. The smaller the tubing, the slower the flow rate. And then we have increased resistance to flow can be caused by the roller clamp being in a closed position. There could be kinks in the IV tubing. Also the viscosity of the IV fluid, even a small lumen IV catheter, a small vein, or also the presence of clots in the IV catheter. Gravity flow infusions are measured in drops per minute. To initiate a gravity flow infusion, open the roller clamp in small increments every 15 to 30 seconds, and you count the number of drops falling inside the drip chamber until the desired flow rate is achieved. You monitor that frequently, as a change in the position of the patient's arm or hand can actually change that IV flow sheet. That's why it's very dangerous not to have these fluids on a pump. A time tape can be applied to the IV bag to monitor the infusion rate. When the infusion is started, write the time on the time tape, and for every hour that passes, the fluid level in the bag should decrease by a predictable amount. So you should check on that periodically to make sure that you accurately counted those drops per minute, so that if the patient is supposed to get, for instance, 100 mLs an hour, that's exactly what the patient is getting. So if you mark it hour by hour, you should see that fluid go down at that hour interval. That's how much the patient is getting. Manual gravity flow infusions do not require special equipment, and this may be very helpful when obviously there's no power available. However, they require frequent monitoring by the nurse. They carry a higher risk of fluid overload if the flow rate increases accidentally. And again, if you have somebody coming in there and affecting or touching that roller clamp that may change the flow rate, that's also going to be a very serious issue. So conversely, if the flow rate decreases accidentally, the patient may not be getting the amount of fluid he needs. But I think we're pretty good about checking our patients frequently through the hour, and we would know right away if the patient was getting too much or not enough. And you might have a patient that after maybe a surgical procedure, they might have a PCA pump, and those patient-controlled analgesia refers to a pain control system regulated by the patient, allowing the patient to receive medications immediately. PCAs are infusion pumps that deliver a small amount of pain medication, such as morphine or fentanyl or hydromorphone, to the patient on demand, and the patients really have the control of giving the amount of medications they need. They provide a more steady blood level of medications than a large intermittent dose. And these are just the different types of PCA pumps, okay? So and there are safety features that include a lockout interval, so the patient can't give themselves too much medication, the dosage of medication received by the patient, and then PCA pumps are locked to prevent access to the syringe of medication and to prevent changes to the program by anybody who's not authorized to do so. So some of the nursing responsibilities with PCA pumps is recognize which patients are appropriate candidates for a PCA pump. Patients with cognitive deficits or physical limitations may not be able to self-administer pain medications. And carefully monitor your patients to ensure that the pain is controlled without adverse side effects. You know, if they're getting a opiate or a narcotic, make sure they're not too snowed and that they're able to, provide that pain medication on their own. So the nurse is responsible for providing adequate patient and family teaching. Patients should be shown how to activate the PCA button, when to push the button, and how to notify the nurse if their pain is not well controlled. And family members should be instructed never to push the PCA button on behalf of the patient. Family members may not recognize the signs of an impending narcotic overdose, and that's a very important point made when teaching family and the patient themselves. Some of the other types of pain pumps. Providers may order other types of pain pumps for patients who have undergone surgery or who suffer from chronic pain syndromes. There are specialized infusion pumps that can deliver medications into subcutaneous or even into intramuscular tissue as well. And some pumps infuse narcotics, local anesthetics, or a combination of both into surgical sites, joints, knees, hips, or shoulders, or into epidural or intratracheal spaces. Pumps may be surgically implanted into the body or may be clipped to a belt or trouser waistband. So that's pretty much chapter 12 as well. Okay, there's also a video by Nurse Sarah that I have uploaded into your Canvas course that she does a very good job of really explaining hypertonic, isotonic, and hypotonic solutions. And then there is also a little bit of information in your Adams book, 6th edition, on page 339 that also explains those types of solutions. Okay, and again, this is chapter 12 and even chapter 13, which I'm not going to go over now. I'm going to get into the medications on the next video. But please look at chapter 13. It really is labeled intravenous calculations, where I want you to start looking at time, infusion times, and then completion times. And then it will also give you information on how to do drops per minute. And I will definitely go over that in a separate PowerPoint as well. All right. So, but I want you to begin reading that chapter and know what information that you need to be able to calculate drops per minute. All right. And then, because I want you to be able to do those before your second test, which is in week 7. All right. Because I want you to know how to do those particular problems. And that particular chapter is, let me give you that page number in your DA book when it talks about chapter 13. Okay. Yeah, chapter 13 starts on page 218, and it's called Intravenous Calculations, Calculating Flow Rates for IV Infusions. And again, it gives sample problems on milliliters per hour, which you did very well on the test with those. And then it gives you practice problems to calculate milliliters per hour and flow rates for continuous IV solutions. And then after practicing those kinds of problems, you'll see some examples about how to calculate infusion times and then completion times. And with a completion time, they have to give you when that IV was started. So if it was started at 10 o'clock in the morning and the IV is to run for 8 hours, then what we mean by completion time is that it would be completed at 1800 hours. Okay? It'd be 8 hours later from 10 a.m. in the morning. All right? So there are some practice calculating infusion and completion times as well. And then again, talking about how to calculate drops per minute, which is a manual way to control how many drops per minute and how many milliliters per hour the patient will have infused. And what we mean by that is IV infusions may be controlled manually when you don't have an available IV pump or controller. And the nurse regulates that flow rate by counting the amount of drips that fall inside that drip chamber, okay, over 1 minute. So it's necessary that the nurse have a watch so she can accurately count for a full minute. And so that adjustment of drops per minute is controlled by the nurse by opening or closing that roller clamp, by even moving it up or down the tubing. And as I said from this PowerPoint, those IV infusions that are being manually controlled really do require a lot of careful monitoring, because there's no alarm or built-in warnings that tell you that the IV is going too slow or going too fast. And if you've got a patient who might have some cardiac issues and might have problems with cardiac overload, and that IV infuses in too fast, say for instance, the patient is supposed to only get 50 mLs an hour, and all of a sudden, you go in there and for some reason the patient had 500 mLs infused in less than an hour, that could be a very serious situation for your patient that can actually go into an acute exacerbation of heart failure. And again, we have to worry about, too, where those IVs are being placed, because if it's in an antecubital, which we really don't like to use that particular area for IVs, if the patient bends their arm, they're going to close off that IV, and there's no pump to have an alarm go off, so you may not know that the patient is not getting what they're supposed to have ordered every hour. So that's a real big problem. And also, hanging those IV bags too high above the patient can also increase the flow rate. Hanging the bag level with the patient can also slow or stop the infusion all the time. So to calculate a flow rate, here's what needs to be in the problem, okay? First of all, you have to know the drop factor of the tubing, which can be found on the tubing package. So you'll need to know if it's 10 drops per ml, 15 drops per ml, 20 drops per ml, or whatever, or even 60 drops per ml. And then you'll get a certain amount of fluid that needs to be infused, all right? And the length of the time. So the problem may say the patient is to have 1,000 milliliters of IV fluid of D5 in water infused over 10 hours. The drop factor is let's say 10 drops per ml. What is the gravity flow rate, or what are drops? How would you calculate drops per minute? Okay. So that's how you would do that calculation. So you do need those three components. You need the drop factor of the tubing. You need the fluid volume to be infused. That's obviously ordered by the physician, and you need the length of the time for infusing the flow of fluid, as also ordered by the physician. So you have to know how fast that IV fluid should be going. If it's over 10 hours, 4 hours, 6 hours, or whatever. So, and then knowing that, you're going to be able to solve that equation. Okay. So usually what I do is outside the margin, I put drops per minute. And obviously if we know the drop factor, then I would put 10 drops over 1 ml. And then you would put in the next parentheses, say for instance, it's 1,000 over 8 hours. So you put 1,000 milliliters over 8 hours, and then you're going to convert that hours to minutes. So you would put 1 hour over 60 minutes, and then your hours will cancel out, your milliliters will cancel out, and all you'll have left is drops per minute. And then you just plug in your numbers and multiply those numerators and divide that by the denominator that you get. So it's not that hard. So look at the examples. They really spell it out very, very nicely for you. And practice doing the problems at the end of the chapter. All right, so I hope that makes a lot of sense. I'm just making sure. And there's an example, too, of what we talked about on this PowerPoint, making a time tape, how that fluid level should start descending as, say, for instance, if the patient's supposed to get 100 mLs per hour, you should see 100 mLs per hour kind of descend, especially if you put a time tape up there on the bag. Okay, so I think that's all from chapter 13. So a lot of problems to practice with, especially from page 242 to page 244. All right, so I hope that explains a lot from your DA book, especially with chapter 14, chapter 12, and then again with chapter 13 on how to do these intravenous calculations. All right, thank you very much for your attention, and let me know if I can help you with any of this dimensional analysis, okay? I want to make sure you understand this. I really want you to feel comfortable with DA, especially as we continue to practice these problems. I want you to feel very confident and be able to set up these problems very quickly before you leave Nursing 124, so you're very, very well prepared in doing DA problems when you get to Pharm 3. All right. Thank you for your attention.